Hello, thank you for joining us today. My name is Bill Furon. I'm the Director of Interventional Cardiology at Stanford University. And it's my pleasure today to be joined by my good friend and colleague, Dr. Jennifer Tremmel. Dr. Tremmel fills many roles at Stanford. Two of them include being the Director of the Women's Heart Health Center, and the second one is the Director of our Chronic Total Occlusion Program in the Cath Lab. And we're going to spend a few minutes talking about both of these roles. Thanks for joining us, Jennifer.
Happy to be here.
So first of all, why do we need to focus specifically on women's heart health?
Yeah, well, there are a lot of differences between women and men, and not everybody knows, so I think it's very important that we understand those. So there are differences even from the level of prevention and how we treat our patients. So women are often undertreated, and their risk factors are not as aggressively treated as they should be. A real big difference that we really focus on at Stanford is angina, or having chest discomfort. And actually women worldwide have more angina than men. And in the United States, it's higher, and it's even higher among women who are of non-white groups. And so the interesting part, though, is that men actually have more coronary artery disease than women. So the question is, where is this chest pain coming from? Because we usually think it's coming from a blockage. And so at Stanford, we really focus on what's going on with these women patients that are having chest pain, but they actually have no blockage. And it turns out a lot of them have very stable symptoms, and they get this on a daily basis. And then other ones come in and they're having a heart attack, but they actually have no blockages. So there's kind of two groups of patients that we are dealing with, more of them women than men. We do see men like this as well. But those are some of the important things we look at. I would also add pregnancy is a big thing. Obviously, men don't have that. Yeah. And we see a lot of risk factors present themselves during pregnancy, and we also see cardiac complications during pregnancy that need to be addressed. And so that's something that we can focus on too.
So some of these patients end up in the cath lab, and you do coronary angiograms on them. And as you mentioned, both women and men can have chest pain and have normal appearing coronaries. How big of a problem is that, and why is it important?
Yeah, interestingly, over 20% of patients that come into the cath lab for an angiogram actually have normal looking arteries, and there was some reason they got to the cath lab in the first place. So the question is, what's going on? And something that we do that's special at Stanford and only done in a few centers around the country is we look for other abnormalities that might be causing these symptoms. So one of those things is endothelial dysfunction or spasm, so the arteries constricting when it should be dilating. Another thing is the small vessels don't work. This is microvascular dysfunction. And then a third thing that we really specialize in is myocardial bridging. And this is where part of the heart artery is actually under heart muscle and is getting squeezed when the heart beats. And all of these can cause symptoms. And if we can figure out which one, if a person has this, then we can kind of talk about how do we treat it and have a more directed sort of therapy than try this, try that, let's see what works.
Yeah, so some patients end up getting an angiogram and the arteries look normal, and the doctor says, that's fine, it's not your heart. But clearly it sounds like there's more to it than that. What does the patient expect, or what would be different about the procedure that you would do compared to just a standard angiogram?
Yeah, so it is important that when doctors say that, it doesn't mean that there isn't something wrong with your heart. And in fact, we've looked at patients like this for over a decade and found that if we do this extra testing, we will find something in 75% of them. So it's actually a small percentage where we can't find something wrong. Yeah. So when we do this, it's a little longer procedure than just having an angiogram. We do put in medicines in their arteries, and we put wires in. These are things we do on a regular basis anyway, so from our perspective, it's not that big of a deal. Really, we've had no problems doing it over many, many years, as have other centers that do it. So we don't really expect any extra complications.
Yeah, so it sounds like it's a very safe procedure. And speaking of having a better idea of what's going on with them, how do the results change how you can manage the patient?
Yeah, I mean, I think a lot of things are different after that. One is our goal is to stop kind of the cycle of trying to find a doctor that'll actually listen to you, going to the ER where they stop listening to you as well, stop getting tests that you don't need that are going to show everything's fine. So hopefully that whole thing stops. In terms of medical therapy, we've figured out what medicines seem to help. There are some small trials that have looked at this. It's definitely an area we need to work more. But we can guide therapy in that way. And in fact, in some of the patients who have this myocardial bridge and have failed therapy, we do surgical unroofing. So we actually cut away the heart muscle that's constricting the artery and release that. And for a lot of patients, it's very life-changing. It can happen when they have a heart attack as well. And so there's an entity called MINOCA, or a myocardial infarction with normal coronaries. And so again, at Stanford, that's something we're paying a lot of attention to, and we actually try to find out what's going on, because another one of the questions that women come in to me with is not, why do I have chest pain? Well, why did I have a heart attack? Because everything looked fine. So MINOCA is important. Some people have heard of Takotsubo, which is another thing we see predominantly in women. And then SCAD, which is spontaneous coronary artery dissection, is something else that people come in with, and we definitely specialize in.
Great. So that's very useful information. Why don't we switch gears and let's talk a little bit about chronic total occlusions, or chronically occluded coronary arteries. Can you tell us what that means and how big a problem it is, and why is it a problem? Yeah.
When we look at these blocked vessels, so this is a kind of on the other end of the spectrum, right? So we have people with totally open arteries, and then we have people with totally closed arteries. In interventional cardiology, we're really good with, a 70 to 90% blockage. It's pretty easy to put in a wire, balloon it, and stent it. These total blockages can be really hard to open, and traditionally we haven't pursued them because we didn't have the equipment to do it. We didn't always have the skill set to do it, and that we meaning the greater world. So CTOs have generally been ignored. We know that 20 to 30% of people that have an angiogram, even higher in more male populations, will have CTOs, but only about 10% of CTOs actually get opened. And these CTOs are causing chest pain in patients, right? They're limited, even if they're getting some blood flow by their own kind of bypass that they've made. It's typically not sufficient, and so they can't maybe exercise as much as they want to, or even engage in activities of daily living as they want to.
Yeah, and can you describe how the procedure for CTO is different than a regular coronary angiogram?
Yeah, so these procedures are longer, so they can take us several hours. I do tell patients sometimes we actually need 2 attempts, that we learn as we go along. Sometimes everybody's artery is different. We use specialized equipment, so we have lots of different wires depending on what this blockage is like. We use little catheters we're trying to get across. We may need to bring out the rotablator, which is like a roto-rooter to drill through, or a laser to break up calcium that's in there. So there's lots of different equipment. The procedures take a while to do. In general, though, we feel with possibly a repeated attempt that we can get about at least 90% of these open, and it can be life-changing for people in terms of feeling all better.
Yeah. So speaking of the results, what has been your experience, and what has the data shown as far as success rates and also the benefit for the patient?
Yeah, so there aren't a lot of randomized controlled trials in this area. It's hard to do that, partly because there aren't a lot of operators that do these cases, and the cases can vary, obviously. But the observational data we have is that people do feel better. And I would say that's probably the biggest thing I've seen is it's quite dramatic how much better people feel. It's very satisfying to see them afterward. And people can exercise more after they get this done. People who don't have good pump function, with a lot of the observational data, you'll see that improve. In some people, even where their pump function doesn't improve, they still seem to have less heart failure symptoms and are able to come off some of their medications. So there are a lot of positive benefits that we see like that. And we think that ultimately it outweighs the risk, because there are more risks with this when we're putting in more equipment and working longer and trying to get through a total blockage.
Yeah. Great. Well, this has been really instructive and informative. Thank you for joining us, and thank you for joining us today.